Sure.
Where's that
It looks like somebody's.
at? MBL PC. Oh, character.
Yeah.
X-ray.
Yeah.
Maybe because the PowerPoint in my computer on and off. Maybe because of the you have too many.
It's I had I don't know if since I had to upgrade it to the Windows 7, this stuff's been moving a little slow, like on my computer at home or my computer at work. I'm sorry. So yeah, but, all right, I think
Perfect.
the only thing um, we're on two screens
Okay, there we go. It's back on. It was Colin Grayson. Anyway, so we're good. Sorry I had to call you. All right, have a good day.
here. Yeah.
Bye bye.
Oh, here you go.
Like a phone notification.
Yeah.
You cannot. Okay. Excellent. But I can do it.
Yeah. This water's freezing. I'll wait to put that thing on yet. So I think other than that, we're in good shape. And of course, drop the lights. We'll drop the lights when you start speaking.
Backward, and I will move to the front. Excellent. Thank you very much.
Yeah, probably.
You probably can understand his accent. I still can.
Who's Julio? Yeah. I've gotten used to it. Thank you.
How often do you use map tens? How often do you use? I saw one of my patients.
Good morning.
Pretty seldom.
Welcome to the Department of Medicine Ground Rounds. Before we start, I have a guest, Dr. Grubbs from Cardiothoracic Surgery. He's going to make an announcement that it's an important conference that I urge you to consider attending.
You're not on an inpatient right now, are you?
As I stated, my name is Kendra Grubb. I'm one of the cardiovascular surgeons at the University of Louisville and Jewish Hospital. Wanted to bring to your attention a symposium at the end of June, June 28th. It's a one-day symposium for physicians, allied health professionals, and even all the way down to the community. It is an update on the treatment and prevention in heart disease in women, and it is free to all students and all residents and fellows, so I encourage you to register. A small fee for physicians to attend, but like I said, there is CME included. So I will leave some flyers in the back if anyone is interested. Please share this with your office staff, your nurses, and anyone who might be interested in heart disease in women. The symposium will go from all the way from management of heart failure, medically, to advanced devices, transplants. We'll talk about coronary disease, we'll talk about valvular heart disease, and everything in between. So it should be a great learning experience for anyone interested. Any specific questions?
Where is it again?
It's at Jewish in the conference center on the top floor. Yep. All right. Thank you very much.
Thank you so much. You're welcome to come again. Dr. Grubb left, and now we don't hear voices. Something happened. A couple of announcements before I let Dr. Ramirez up to the stage. This is always a fairly awkward room because I never know which screen to look at, but you will figure that out soon. Number one, I want to let you know that Dr. Barbara Casper has been named the new division chief for general internal medicine, and you'll hear or you'll see a formal announcement about that in your email in the next week or so. And of course, she has worked for many, many years as the vice chair of medicine for education and as program director for the residency program, and that program will now be taken over by Jen Cook, who's here on my left. And they've done this work for a number of years. They will continue to do a terrific job, and I hope you continue to assist them in their efforts to provide the best top education we can to our residents and fellows. I also want to announce that the Institute for Molecular Cardiology, led by Dr. Roberto Bolli, won the Healthcare Innovation Award during the MediStar Awards presented on May 13th in Louisville at the Hyatt. And this award is usually given for innovations to an entity who is involved in development of new program services or devices that actually accelerate delivery of medical care. And of course, the Institute for Molecular Cardiology is involved and it's at top of their game in the area of research and cardiovascular research, particularly congestive heart failure and ventricular dysfunction. So congratulations to the gang at the Institute for Molecular Cardiology. The other person who won an award that day was Dr. Donald Miller, who's, since he's not here, I think, you can go upstairs to his office or actually at the Cancer Center and celebrate him. He's the head of the Cancer Center, and he won the Physician of the Year Award, which is delivered to someone who has outstanding leadership and vision and has contributed to its workplace in a way that has a lasting legacy. And Don, we know, has done that for this Cancer Center. So celebrate him as well when you see him. Today is an interesting day. In 1988, on this day, nicotine was declared to be addictive in ways similar to heroin and cocaine by the report by the Surgeon General at that time, Dr. Everett Koop. Many years before, on this week, was the death of Sir Frederick Golan Hopkins. Sir Hopkins was an English biochemist who shared the Nobel Prize with Dr. Ekman in 1929, Nobel Prize for Medicinal Physiology, for the discovery of nutrient factors or vitamins. And what he initially did was that he fed rodents, rats, with a very basic diet that contained a few salts, a little starch, a little lard, a couple of things like that, a little casein, and then found that over time, these animals stopped growing. So what he did is to start adding things to that basic diet to find out what would recover, engage them to grow again. And he found with the 2 or 3 cc's of milk a day per animal was just enough to get them to grow at the normal rate again. And therein started the search for what's in that extra diet that makes a difference, and later the discovery of vitamins and so forth. In 1845, and this week was the birth of Ilya Menikov. Today is an infectious disease day. So Ilya Menikov, you need to know about him. He's a Russian-French bacteriologist and zoologist who also shared the Nobel Prize of 1908 for recognition of his work in immunity. He had the idea that there were blood cells that actually were capable of engulfing and digesting bacteria. And at that time, nobody believed him. And so in 1882, about 40 years after he had been born, had been a nice career as an educator in academia, decided to leave it and went to develop a private laboratory in Messina to just focus on this work, and discovered phagocytosis. So that's important for you to remember. So today, I want to introduce Julio Ramirez, who doesn't need introduction. He was just here a few weeks ago talking about global health. Today, he's going to talk to us about another program, the Bone and Joint Program. It's interesting that he's here in May, because in May was the birth of Evita Peron in 1919. And a few years later, quite a bit years later, Dr. Ramirez was born and became an MD in 1975, a fellow at Louisville in 1987, became part of the faculty in 1989, and became chief of the Division of ID in 1995. And he's done tremendous work. He has an international reputation. His research has attracted students, residents, and investigators all around the region, and you'll see yet another reason why that is the case. Julio.
Thank you very much. Oh, thank you. As Dr. Roman mentioned, what I want to review today is another program that we have in the division. That is the Bone and Joint Infection Service, and the voices return. You have to be talking. Yes. Another program that we have in the division is the Bone and Joint Infection Service program. That really, this program started several years ago with our interaction mostly with the orthopedic group at the university hospital. And during the years, I have several junior faculties that have been leading the program. At this moment, I'm leading the program again because the last faculty that was in Bone and Joint also went to private practice. This is another service that have a problem, that have junior faculties that stay for a couple of years, then go to private practice. And we are actively searching for a new faculty member that's going to join to lead this program. What I'm going to do today is discuss with you the classification of bone and joint infection, pathogenesis, treatment, and one of the studies that we are doing in the area. And regarding, I'm going to take some time in the topic of classification because for us these are becoming common infections that are not so common sometimes for internal medicine. And I also want to give the principles that we have for treatment of this infection. Most of the bone and joint infection is happening in this area. It's happening when we go from the epidermis, the dermis, the fatty tissue, muscle, and then you get all the way to the bone. Then this is the anatomy. This is the area that we're dealing primarily with bone and joint infections. And I'm going to be discussing one by one. And the first one, going from the surface, will be cellulitis. And we know that cellulitis is an infection that is going to, the inflammation is going to be in the epidermis, a little bit of the dermis. And cellulitis, at this moment, there are three primary organisms. Group A is Streptococcus, or Streptococcus pyogenes, the methicillin-susceptible Staph aureus, and the methicillin-resistant Staph aureus. For any one of us practicing medicine for more than 10 years, 10 years ago, 15 years ago, before the emergence of the community-associated MRSA, cellulitis was no-brainer. Staph aureus, MSSA, or Group A strep, first-generation cephalosporins, go home, everything is fine. Okay, cefazolin or Keflex for everybody. But now, at the end of the 1990s, 2000, now we have the new community-associated MRSA pathogen. And now, all of a sudden, the person with cellulitis may be infected with MRSA. This is why, in the most recent classifications of cellulitis, cellulitis have been divided in what is called non-purulent cellulitis versus purulent cellulitis. And here you have the regular lower extremity with redness, that this patient may have group A strep, MSSA, or even MRSA. But the patient that you see, for instance, this arm, and there's a little bit of pus there, then essentially, if you see a cellulitis with pus, this is MRSA, period. Then we try to separate what is going to be MRSA or not. But now the challenge is that how do we treat this patient empirically when there is the possibility for any cellulitis to have MRSA? Then one question is for sure. The old paradigm of cefazolin for everybody, everything is going to be fine, doesn't apply anymore, because now we have the possibility of MRSA as a cause of cellulitis. And then we describe this as non-purulent or purulent cellulitis. Then we move to a very important classification of skin and soft tissue infections. They are the ones that are associated with necrosis. Then this is going to be necrotizing skin and soft tissue infections. And when we discuss necrotizing, the necrosis may be necrotizing cellulitis, that of course will be superficial, maybe necrotizing fasciitis, or maybe necrotizing myositis. Then anatomically, this is probably the best way to classify this, even though this type of infection, you read different textbooks, you have different forms of classification. For necrotizing cellulitis, then you can see that the epidermis is going to be dead, and it's going to be a little bit of the dermis involved. This is going to be, by definition, a superficial infection. Then Clostridium perfringens or polymicrobial are the organisms. This is going to be a small trauma to the skin. Now, when you see a necrosis of the skin with a little bit of cellulitis, there's no way to know clinically how deep is going to be this necrosis. And all these necroses are going to involve surgical intervention and debridement. In this case, the patient has cellulitis, is going to be small debridement because it's just superficial. If we move to necrotizing fasciitis, then you imagine that, as you see here, the damage starts in the fat tissue, in the fatty tissue. And then the inflammation may reach the skin. Then in the skin, you're going to see necrosis with necrotizing fasciitis, but the problem is deep in the fascia, and the fat is going to be dead. Then the person is going to get, for instance, lower extremity. You see this necrotic skin. The organism for necrotizing fasciitis is called necrotizing fasciitis, the type 1, that is polymicrobial, or the type 2, that until recently was just group A strep. Then you have necrotizing fasciitis, group A strep. Remember the flesh-eating bacteria, okay, group A strep, and we know that in, all over the world, in Europe, in Australia, in the United States, have been reports that necrotizing fasciitis is becoming more common. Why? Because probably one thing, the group A strep is becoming more virulent, and then we have a new bacteria in the field of necrotizing fasciitis that is community-associated MRSA. Because before the community-associated MRSA, necrotizing fasciitis was not on the list of infections that MRSA may cause. Then what we have here is either polymicrobial, group A strep, or MRSA. The necrotizing fasciitis most common is in the lower extremities. You know that if you have necrotizing fasciitis in the perineal area, may happen in females, mostly in males, then you have Fournier's gangrene. And Fournier's gangrene is every time that we have a patient in the unit with fever, or any diabetic patient with fever, we know that examination of the perineal region is critical because, again, at this point, when you have necrosis of the perineal region, I mean, you don't need to be a doctor to figure out that something is wrong, okay? And what we see here after debridement, you can see that the skin, the dermis, all the fat is gone, but usually the muscle is healthy. Because in necrotizing fasciitis, it's not an infection of the muscle. Then debridement all the way to the muscle, and everything is going to be, everything is going to be fine. The patient is going to survive. This will be for near gangrene. Now, one of the challenges of necrotizing fasciitis that we see this over and over is how do you make if the patient has necrotic skin, well, we know, we're going to call the surgeon, something is wrong. How do we make the diagnosis before the infection reaches the skin and the patient has necrosis in the skin? Because we can clearly see that initially the fat is going to be infected. We have the MRSA here causing the necrotizing fasciitis. In the first 24 hours, the skin may be normal. The infection didn't reach the skin, the tip of the iceberg. At 48 hours, the person is going to have a red skin. The skin is not going to be necrotic yet. The skin is going to be necrotic when the infection here affects the veins, the arteries, and finally you have a necrotic skin. Then you have a patient that presents what clinically looks like cellulitis, because it's just, at this point, the initial skin is going to be red. Then you have a red skin in a patient with fever, then diagnosis cellulitis. Then what is the clinical characteristics? When? Because we know cellulitis, antibiotics. Necrotizing fasciitis is surgery plus antibiotics. Without surgery, the patient is going to die. Then what is the key point for us to call the surgeon or to call ID, where they will say this cellulitis is not just cellulitis? Well, a couple of things. The primary one is that the patient is toxic out of proportion. If the patient looks septic, whatever, the systemic inflammatory response, the fever, the tachycardia, leukocytosis, whatever you call in your mind, oh, this patient doesn't look good, looks septic, and it's a mild cellulitis, nobody can be septic for a mild cellulitis. Then it may be something under the cellulitis that is a problem. This is a critical factor. Another factor is that the pain of the patient is going to be out of proportion. Everybody has some tenderness with cellulitis. But with necrotizing fasciitis, I mean, the fat in the bottom is dead, and the nerves are damaged, and the pain is going to be out of proportion. And another important clinical signs and symptoms is that here you can see, for instance, an area of cellulitis. In a patient with cellulitis, remember that cellulitis, the skin, a little bit of the dermis. You press in the area of redness, the patient is going to have tenderness. You get out of the area of redness in cellulitis, there's no more tenderness because there's no more inflammation. In necrotizing fasciitis, you press outside of the area of tenderness and outside of the area of redness, and still there is pain. There is pain outside of the redness because in the bottom the fat is dead. Then essentially pain that is out of proportion or pain that doesn't limit to the area of redness. These are clinical signs that the internist is going to call ID and surgery because this patient is going to need an exploration. Of course, by next day, when the skin is dead, we all are going to figure out that something is very wrong. This is a necrotizing skin and soft tissue infection. Okay, the idea is what do we do in the first 48 hours? Then we move to the other one, that is the necrotizing. In this case, the infection is in the muscle. There is necrotizing myositis. Maybe group A strep, maybe Clostridium perfringens or Clostridium septicum. Clostridium perfringens tend to be the one that can infect anyone. Clostridium septicum tend to be the one that we see in the immunocompromised in the cancer patients. And this may happen just through bacteremia going into the muscle. Even though with Clostridium perfringens usually is inoculation trauma, but it may happen. This is a rare infection. Gas gangrene is a rare infection. But here the problem is that essentially everything is going to be dead. The muscle is dead, then the soft tissue, the skin, and after debridement, what you're going to have is a healthy bone because you go all the way to the bone. Then gas gangrene. Then you can essentially end up seeing the femoral bone. Now it's interesting that we are discussing skin and soft tissue infection. Remember we always discussed this in roundness, bone and joint. If the bone is healthy and the bone has a normal periosteum, you cannot get osteomyelitis. Okay, bacteria don't cross the bone and get osteomyelitis. Then you can get cellulitis, necrotizing fasciitis, myonecrosis, gas gangrene. Doesn't mean that you're going to get femoral osteomyelitis. You have a healthy bone. That is a different story I want to discuss when the bone is not healthy. Then this is, for instance, Clostridium perfringens. This is another muscle that may be Clostridium perfringens. This is the uterus, and this is a patient with a septic abortion. Even though the necrosis of the uterus may happen also as in the postpartum, then it may happen to us here. But usually this is the manifestation of septic abortion, a very common manifestation. You work in areas where abortion is not legal, and this is usually trauma, and this is Clostridium perfringens, and essentially you have another thing that is characteristic of Clostridium perfringens. You don't see too much of pus or white blood cells infiltration. You see only dead muscle, because one of the toxins of Clostridium perfringens inhibit the white blood cells to translocate from the blood vessel. And usually muscle that is dead but without pus. There's no pus because there's no white blood cells. Okay, then this will be then gas gangrene or myonecrosis. Now let's move to another very common scenario that we see in bone and joint, that is the abscesses. And the most common abscess is going to be the superficial abscess. Is group A strep, MSSA, or MRSA. Then this is going to be the three primary pathogens when the person is coming from the community with an abscess. Even though at this moment, the most common cause of anyone coming from the community with an abscess is MRSA, by far. And this happened, is interesting. This is the community-associated MRSA. Then the person is admitted. Abscess is going to be MRSA. We still are going to culture. This will be the subcutaneous abscess. Another possibility, going deep, is that the abscess may be in the muscle, and this is going to be pyomyositis. Pyomyositis is again another. The muscle to be infected either with gas gangrene or abscess is very, very rare. No, how many patients have you seen with possible cultures, bacteremia in all your career? How many times you see an abscess in the muscle? The muscle is very well protected. We don't know why it is. But one thing is, there's one muscle that for us is always an issue. That is going to be this muscle, the psoas muscle. Okay? Then this is the one that if you have bacteremia, for whatever reason, you can get a psoas abscess. And the psoas abscess is an important consideration in the patient with fever of unknown origin. It's an important consideration when we're evaluating patients. And then, for instance, then this will be the CT scan. Here, the left psoas muscle, you can clearly see it's a big collection of pus. And the other consideration, another important consideration of the psoas muscle is that the infection may go down into the joint, or the psoas muscle is attached to the vertebra, and the infection may move up into the vertebra. And then we get into another problem, that is infections on the spine. This can go both ways. The patient may have vertebral osteomyelitis that complicated with psoas abscess, or this may be a psoas abscess that complicated with an infection in the vertebra. And then, if we are discussing abscesses, then I'm going to present this. Then another important abscess that we see in this concept of bone and joint is that we look at the spine, and I imagine that this is a vertebral body. Here in blue is what is called the epidural space. Then around the spinal cord, there is the epidural space in the anterior and the posterior. The posterior epidural space is bigger, and in the epidural space, you have all these blood vessels, you have this mostly fat, and you have veins and arteries. You imagine, the patient has bacteremia. Okay, this is a perfect place for bacteria to stop and develop an abscess. Then the most common abscess due to bacteremia is going to be the posterior epidural abscess. On the other hand, if the patient has vertebral osteomyelitis, that is also common, then from the vertebral osteomyelitis, the patient may develop an anterior epidural abscess. And we all recognize that epidural abscess is a medical emergency because this abscess progresses and immediately is going to produce a spine compression. Then another important, and I have to tell you that if you rotate through ID, there is not even a single month that in our patient management conference is going to be a patient that is a 60-year-old that, started with back pain and a little bit of feeling poorly and go to the ER and get the non-steroidal and continue with back pain. And then sometimes we see that there is some weakness and nothing happened. and there is more weakness, and then there is urinary retention, and the patient has a Foley catheter, and then the case is being presented and say, when we are going to get the MRI, because this is a spinal epidural abscess, and nothing happened until the patient is paraplegic. I said, why is that we're not thinking that spinal epidural abscess, even though it's real, is a medical emergency, and the patient needs to have decompression before there is compression of the spinal cord, and the patient develops paralysis. Then this is a very important consideration for us. In this case, for instance, you can clearly see here the abscess that is located in the posterior. This will be a posterior epidural abscess. Okay, then this is the most important abscesses that we are seeing. Now we change to another thing that we are seeing. Then we see the infection, the necrotizing infection. We see the abscesses, and I think that we see a lot of ulcers in the skin. When we have an ulcer, of course, that the bacteria, the normal flora of the skin, now is going to be normal flora of the ulcer. Then essentially, we never swab an ulcer to see if the ulcer is infected, because it will be the same as swabbing the skin to see if the patient has a skin infection. Okay, then please don't send a swab of an ulcer to see what is the cause of the infection of the ulcer. Okay, we are going to over-treat with antibiotics, unnecessary. Now, if the patient has, and we just here in this red area, invasion of the tissue, then essentially what we're going to get is a tissue biopsy. We're going to do colony counts. We're going to see the abscess is infected or not. Of course, we are discussing here an ulcer that looks good. If the ulcer is purulent and necrotic tissue, you don't need to, you know that it's going to be an infection. What is the most common ulcers that we see at the University Hospital, the bone and joint, is going to be the cubitus ulcer. And we know that the cubitus ulcer, the management is going to be, most of the time, is going to involve debridement, surgical debridement. And one of the issues is, okay, is the ulcer, I put here, is the ulcer all the way, the bacteria all the way to the bone, meaning that you have the cubitus ulcer with bacteria getting into the bone. Well, we try to probe to bone, we always feel. Sometimes after debridement, there's no question, because sometimes you see the bone. The bone is exposed. Sometimes you see the necrotic bone. Or you get an X-ray that you see a total destruction of the pelvis. Then it's very common to have a bad decubitus ulcer associated with pelvic osteomyelitis. This association is very common. Now, then we get called. And what is our answer to a patient with a pelvic osteomyelitis with a big decubitus ulcer? The ulcer is that the bone is infected. The patient has osteomyelitis. They say that in this bone here there is E. coli, because this, of course, is strep, MRSA, MSSA, enterococcus, anaerobic gram-negative. Essentially, is whatever is in the stool, maybe in the pelvic bone. Because whatever is in the stool is in the decubitus ulcer, and whatever is in the decubitus ulcer may be in the bone. Then let's say that we have E. coli in the bone. Okay, well, yes, we can give 6 to 8 weeks of some antibiotics, and we probably, we may even get rid of the E. coli. What is going to happen when I stop antibiotics? What is going to happen next week? It's going to be an enterococcus. And if I treat for enterococcus, in 2 months, it's going to be an MRSA. If I treat for MRSA, it's going to be a Pseudomonas. Then essentially, if I have a stool in contact with the bone, what is the reason to treat osteomyelitis? Just to give unnecessary antibiotics. Then when do we treat pelvic osteomyelitis associated with a big decubitus ulcer? When we have a surgeon, a plastic surgeon, that says, you know what, I'm going to put a muscle flap, then I'm going to cover this, then we are going to put a muscle, and then we are going to treat, because now we hope that we are going to have a clean bone, a clean muscle, and everything is going back to normal. Now, we call the plastic surgeon, and the plastic surgeon says, you know, this patient, he continued to smoke, have severe, it's not a candidate for surgery, there is vascular, they're not going to put a muscle flap. We just don't treat. Essentially, the patient is going to have chronic osteomyelitis with a bone exposed for the rest of his or her life. Okay, this is the thought process why we don't use antibiotics. And this is one of the most common reasons of overuse of antibiotics in patients in nursing home or in chronic care facilities. There is a piece of the bone that is exposed, and people keep getting pieces of the bone and keep treating, assuming that magically the bone is not going to be infected tomorrow when you have a bone exposed to a stool. Okay, another common ulcer for us, the diabetic foot ulcer. And this is anyone that rotating our bone and joint infection. This also, we work a lot with our orthopedic colleagues, and we work a lot with our podiatrists. And we have an excellent podiatry service at the University Hospital. Okay, then I have to tell you, it's the same podiatrist that goes to Jewish, but we have an excellent, we have a podiatry residency program. We always have a podiatrist in our bone and joint infection service. And one thing is that you know, we clearly have established with our podiatrists at the University Hospital and our podiatrists at the VA Hospital the approach that osteomyelitis requires surgery plus antibiotic. Surgery to remove the necrotic bone and antibiotics to treat the pathogen that causes osteomyelitis. Never empiric antibiotics. Always is pathogen-directed therapy. How do you do pathogen-directed therapy? You need to have bone biopsies. Then no question with our podiatrists, bone biopsies happen always. Then the patient is admitted with and of course, here we're discussing the ulcer. Not every ulcer is going to have osteomyelitis. Then essentially what we have here is we always probe to see if we feel bone. If you probe and you feel bone because you hit the bone, essentially by definition the patient has osteomyelitis. Why is that in this case? If I reach the bone, there is osteomyelitis, and not in a patient with gas gangrene. Because again, the bone here is never normal. The bone in an ulcer is abnormal. Then the patient with a diabetic foot develop an ulcer, and you have abnormal skin, abnormal dermis, abnormal muscle, abnormal bone. Then if the bacteria reach the bone, the patient, if the ulcer reach the bone, the patient has osteomyelitis. Then when we probe to the bone, there is osteomyelitis. Then a patient with cellulitis and ulcer, we probe this bone, and of course, in this case, in the X-ray, you see a destruction of the bone. Then, for instance, this patient, we see clear destruction of the bone there. Are we going to treat with antibiotics alone? No, the patient needs debridement of the dead bone and then antibiotics. Because again, dead bone doesn't get treated with antibiotics. Dead bone gets treated with surgery. Then it's going to be, and of course, and this is why it's also important the podiatry here, because you have to be a minimal debridement. Okay, just the minimal debridement of the necrotic bone, and then a nice biopsy to figure out why is the bacteria. And another thing that we are doing is that in this patient, sometimes let's go back to this patient. You see this ulcer here. You see that the ulcer looks good. There is definitely not cellulitis. And we probe to bone. This patient get admitted to the hospital because you're going to have surgery. Okay, no antibiotics in this patient before surgery. The patient doesn't. Now the patient has osteomyelitis. Osteomyelitis is never a medical emergency. It's never an infection that you need to use antibiotics. The patient with osteomyelitis will never develop sepsis, severe sepsis, and die. Then this patient with osteomyelitis get admitted to the hospital, no antibiotics, goes to the OR, we get a biopsy, no antibiotics. We want to get the bacteria. After the patient is removed from the OR, we start antibiotics. We start broad spectrum, but in 2 days, when we have the bacteria, we treat according to the culture. Then don't start the patient on vancomycin, piperacillin, tazobactam, because the patient is admitted to the hospital to have a surgery tomorrow, even though the patient has a bone infection. Now, if the patient has a necrotizing fasciitis with cellulitis, with osteomyelitis, we treat the necrotizing fasciitis. Then if the patient has severe skin and soft tissue infection and bone infection, we need to give antibiotics because with severe skin and soft tissue infection, you may develop sepsis and die. But the patient gets admitted just with osteomyelitis. We don't want antibiotics before the patient goes to surgery because we need to identify the organism. And this is, for instance, we're doing this very well now with our podiatrists here. We have patients admitted to podiatry for biopsy. They don't even start antibiotics. But we have years of podiatry residents rotating to our service and essentially no antibiotics, then we get a best biopsy. This is This is a patient that we have not long ago. And this, I brought this case to emphasize that the importance of glucose control in diabetic patients. Because this patient has been seen by our podiatrist group, and the patient was stable. The ulcer was not healing, but it was an ulcer that was stable. And for reasons that are unclear to us, to the group, the patient decided to stop taking the insulin. Initially it was because there was some discussion if he lost insurance or not, but for 3 weeks he stopped taking the insulin. This patient is young, Martinez, he's 35. Then he's a 35-year-old, stopped taking the insulin. Well, he arrived, as you see here, with a necrotizing fasciitis, and this is the first debridement. And essentially, now, this is the first debridement with partial amputation. But still, in necrotizing fasciitis, remember that you keep going to the OR. Okay, because you remove all the necrosis, but then by tomorrow there's new necrosis, you remove necrosis, you keep going to the OR every day until finally the necrosis stop. Then the problem of necrotizing fasciitis of the foot, you start removing, and then you have nerves, you have blood vessels. Essentially, the amputation is coming, and then this patient has, this was the partial amputation of the foot. And this looks very bad because there was almost no circulation there. And there was a discussion this is going to be below the knee amputation. The last visit in the clinic, the wound looks much, much better. Probably he's not going to need below the knee amputation, but this is a patient that stopped 3 weeks the insulin. Of course, was admitted with a glucose of 600, but I mean, the importance of glucose control in patients with diabetes, and as this patient remains with half of the foot, is because we are working with podiatrists. In any other place, this patient will have a below-the-knee amputation immediately. But this is diabetic foot ulcer complicated with the worst scenario that would be necrotizing fasciitis. When we have osteomyelitis in our group, we have then contiguous spread, hematogenous spread, or direct inoculation. And essentially, in our database of osteomyelitis, because we've been doing a database for some time, and this is another important consideration is in our bone and joint service. We have also clinical pharmacists from Sullivan that are interacting with us. We have students from pharmacy from Sullivan University. We interact with podiatry, and then we have more and more internal medicine residents that are rotating with our students. And we have a database. We are collecting data, and these are the most common osteomyelitis that we have in our database, more than 300 cases. Of course, foot and ankle is important, but then we have all the cases of vertebral osteomyelitis, a lot of mandible osteomyelitis due to the osteonecrosis that we see, odontogenic infection. Essentially, you name the bone, we have a bone with osteomyelitis in our database. And what I'm trying to say is that osteomyelitis is a very diverse disease, okay, because each one of these areas is supposed to manage a little different. Since I'm giving an overview today, I don't go into detail of every one of the aspects of different infection. A post-traumatic osteomyelitis, this is a big consideration at our university hospital. Remember, we are a university hospital, it's a trauma center, and we are one of the best orthopedics trauma surgeons here at the university hospital. You know that Dr. Sellinson is the one that if you have trauma and you have any one of these open reduction internal fixation and you develop an infection and you are in the middle of nowhere, you are going to be referred to the University of Louisville Hospital with an infection, because here we have the experts, okay, the expert surgeons in this area. This is why it's so interesting to work with this group. Doesn't mean that we agree 100% with the antibiotics management of our orthopedics colleagues, but I may say that from 10 years ago, we disagree 100% of the time. Now we disagree only 10% of the time. That is excellent. Then when my fellows complain, I want to kill this guy, I say, relax. We are doing so much better historically. This is great. But then you have these type of osteomyelitis that are very, very challenging. Of course, the dogma in infectious diseases is that if you have an infection with a foreign material, you need to remove the foreign material. Okay, but sometimes you have this type of infection. I mean, you cannot remove the foreign material because the patient doesn't have nothing, there's no leg. And sometimes we have to treat with a foreign body in place. That is a different, also a challenge. And then we have the prosthetic joints infections with the associated osteomyelitis. I just realized that I have only 20 minutes, and I probably I will have to cut my round short because I didn't realize that I have so many cases to present. But I will try to speed up, even though I've been speeding. These are the most likely organisms that we see. And in any series, you see MRSA is at the top. Skin and soft tissue infections. We have the community-associated MRSA epidemic, MRSA is at the top. But we have then the other Staph aureus, the viridans group, Streptococcus. And it's interesting because we always mention that the strep viridans group, these are non-pathogenic, these are mild organisms. But now we have the Streptococcus sanguis that is very aggressive, is becoming almost like an Staphylococcus. I bring this to say that it's interesting for us that group A strep is not the most common strep. We are seeing at our university hospital group B strep. Another streptococcus that is emergent. Another thing that I want to bring here is the fact that Pseudomonas aeruginosa, that you read in every textbook, and every question that says, oh, Pseudomonas is so common, diabetic foot infection, for us is very rare. It's there, number 10, and only 3.5%. This is why we think that in this type of infection, we don't need empiric therapy for Pseudomonas, but this will be a different topic. Now, community-associated MRSA. This is a new pathogen that started at the end of the 90s and now is the primary cause of skin and soft tissue infections. Since we want to discuss cases, abscess cellulitis. This is bad cellulitis, bad abscess in normal host. A young individual at the university hospital, facial cellulitis with abscess. And we're discussing here any one of us. Young, no problem, small abscess, facial cellulitis. And a person with in the neck here, the other picture, is a little bit of cellulitis, a little bit of necrosis, look like a spider bite. And you know this was MRSA, and this patient has a CT scan with a septic emboli due to this area of cellulitis with mild necrosis. Again, in this cellulitis with mild necrosis, MRSA may cause bacteremia, and then the person may return with problems due to bacteremia. This is a patient also at the university hospital with a young female, healthy, previously healthy, start using a new, the only thing is start using a new gym, and we know community-associated MRSA is a lot of the gyms. And here you have the orbital cellulitis, you see the CT scan, this patient requires surgery. He was having pus, and this is community-associated MRSA. I always mention this is my cell phone pictures, then it's bad. When you get the residence or the other pictures are much better. I bring the point here that this was a New England Journal of Medicine article, necrotizing fasciitis due to MRSA. I mentioned, this is 2005. Before the community-associated MRSA, MRSA didn't cause necrotizing fasciitis, caused almost any other infection. But now, with community-associated MRSA, we have necrotizing fasciitis due to MRSA. And this also is why we have an increased number of necrotizing fasciitis. Because now we not only have group A strep, now we have also MRSA as cause of necrotizing fasciitis. At the same time, we were having the MRSA epidemic here. This group from Los Angeles published in New England Journal of Medicine. Our series were in the Kentucky Medical Journal. But again, it's the same year, 2005, that from our bone and joint service, we collected all our cases of community-associated MRSA. And this patient was a patient that started with a knee which looks like a spider bite. It looks like a small cellulitis, but essentially soon developed into a necrotizing fasciitis soon. That probably was not recognized early. And here you have, after 10 times into the OR, all the fat is gone, the muscle is healthy because this is just necrotizing fasciitis, but the important point is that the patient survived the severe sepsis and necrotizing fasciitis. Pyomyositis. We mentioned infection of the muscle is extremely, extremely rare, except psoas abscess. But now, with community-associated MRSA, we start having more abscesses in the muscle. Again, this is not an epidemic, but now it's a thing that can happen in any normal person. Any one of us may have an abscess in a muscle due to MRSA. Now, this patient is in the ACB clinic, and you can clearly see that something is wrong in one part of the chest. No, this is not. Then you can clearly see that something is wrong here and something is wrong here. What is interesting is that this patient, again, doesn't have cellulitis. You press there is pain, but the patient is not septic. He's in the ambulatory clinic. It doesn't look good, but it's not septic. Still, something is very wrong, and this person is not HIV, is not immunocompromised. In the CT scan, you can clearly see all the collections in the muscles, and he has more than 2 liters of pus in the muscle of the chest, all community-associated MRSA. Then, and the problem that we have is sometimes this is after trauma of the muscle. You may get a transient bacteremia. Then we have all these reports in the literature. Oh yes, he's a 20-year-old that was playing football and now has muscle pain. Well, muscle pain, so what? Take some Motrin, go home. But this muscle pain, yes, may be a little bit of damage during the football game, but now this may be the beginning of a myositis with community-associated MRSA, or this may be the beginning of necrotizing fasciitis. We need to be cautious that all these patients may present with deep-seated infections. There is a syndrome that is called pelvic syndrome, that the community-associated MRSA goes to the pelvis, and community-associated MRSA is an organism that, another big difference is that they can cross planes. And usually, when you have an infection in the joint, the infection just stays there. For a septic joint, you don't get osteomyelitis. We mentioned the periosteum is normal, you don't get to the bone. If you have infection, but here with community-associated MRSA, you can cross planes. This patient, and I show here, you look at the MRI coronal, this young lady in the left leg, in this area, in this area, you see all the infection where she has tattoo done on the left lower extremity. Then she arrived to University Hospital, she couldn't move the leg. Then essentially, she has septic joint, she has osteomyelitis, she has myositis, she has the left side of the pelvis totally destroyed by MRSA after a tattoo healthy in the left lower extremity. Then we discussed osteomyelitis, but this patient was in the ER with a spider bite, mild cellulitis. And then after 1 month, he started coming to the ER complaining of back pain. And then, of course, pain medication, more back pain, until finally the osteomyelitis, you can see also the spinal epidural abscess, and he developed neurological deficit. They finally get admitted to the hospital. Again, these things are becoming more common. Then we cannot apply the same concept of back pain that we were applying 20 years ago. The back pain now is different. It may be one of these vertebral osteomyelitis due to community-associated MRSA, or maybe a spinal epidural abscess. And then you have necrotizing pneumonia, but we're not discussing today this. I want to briefly discuss the pathogenesis and stop there. And when we look at this infection, when we look at this bone, we're looking at the X-ray, we're looking at the MRI. We know that in the bone, at some point, bacteria arrive there, a little bit of Staph aureus. And the bacteria arrive, either contiguous spread, bacteremia, and the bacteria start forming microcolonies of the Staph aureus. Soon after the bacteria form microcolonies, they develop this slime, this polysaccharide, and then it started to develop what is called, it's going to be a biofilm. Then this is an emergent biofilm. Soon after, you're going to have all the bacteria attached. There is cell-to-cell signaling, and essentially the bacteria communicate to each other, what is called quorum sensing. It's almost like the cytokines that you use to talk, and they figure out when they're supposed to keep growing or not, and then finally you have bacteria in a biofilm. This is, osteomyelitis is always biofilm. Then in biofilm, we're not dealing with an MRSA. In biofilm, we are dealing with a MRSA tissue. This is a tissue of MRSA with bacteria at different stages. The bacteria at the bottom of the biofilm, quorum sensing, they stop multiplying because there's not enough oxygen or nutrients going down. They start forming capillaries, and then they keep multiplying. Some bacteria on and off leave the biofilm, and they try to infect other areas. They detach to get dispersion. And essentially, white blood cells, antibodies, antibiotics, they just don't work in the biofilm. And this is the way that bacteria live normally. This idea that we learned in medical school that bacteria are floating around, living as individual organisms, is a fantasy of microbiology. Okay, this doesn't happen for any bacteria under any circumstances. Then we have the prosthetic joint infection, that we have bacteria that are always from the prosthesis into the bone. Then for us, prosthetic joint infection is always prosthetic joint osteomyelitis. And then another thing that we have a lot at the university hospital is the patient has these big surgeries, and then there's a surgical wound infection. And this is a small abscess in the area, and below this you have all this massive hardware. In our book, any infection that is on top of the hardware, the hardware is infected, and the patient has osteomyelitis, and they prove it otherwise, then patients are going to be treated for osteomyelitis. Because if you miss the treatment of acute osteomyelitis, then chronic, you're going to have necrotic bone that's going to be difficult. Some concepts of treatment. Then we have biofilm. In osteomyelitis, in prosthetic joint, when the patient has ORIF, these all have biofilm. But we know that in medicine, biofilm is whenever you have any, for instance, endocarditis, the vegetation is a big biofilm. If there is any foreign material, and you have a lot of infection with foreign material, there is biofilm. Until not long ago, we thought that bacteria form biofilm only in foreign cells. You have to have a catheter. You have to have an IV catheter, a Foley catheter. You have to have a rod. You have to have a foreign material to form biofilm. But now we know more and more that bacteria can form biofilm on top of our cells, on top of our epithelial cells. Then we have more and more infection, for instance, cystic fibrosis, COPD, otitis media, chronic sinusitis, bronchiectasis. These are all biofilm infections. This is why when you have your chronic otitis with MRSA, essentially you are dealing with biofilm. It doesn't matter if you put a needle and you don't grow the MRSA from the fluid. The MRSA is living in the biofilm. You stop therapy, in a couple of weeks the MRSA is out of the biofilm. Then essentially these are all biofilm infections. And what we have here is that these the planktonic bacteria, the ones that are floating around, that the ones that are very easy to kill. Because the bacteria is, but you will never find a bacteria floating around in the environment. You go to the Ohio River, there's a lot of bacteria, but no bacteria is going to be floating around. They're all in biofilm. They're all attached to the rock. They're always, because a bacteria floating around has to be is a suicide. Okay, it's going to be killed by anything going around. Then always bacteria are in biofilm. Then why do we think that bacteria are going to be floating around when we have infections? And the problem that we have is that the report that we get from microbiology is for a bacteria floating around, and this is a bacteria is multiplying, actively multiplying. Oh, beta-lactams kill very good. Yes, when the bacteria is multiplying. What happens in the biofilm? The bacteria is dormant. Okay, this is a new area that we need to understand, how to kill bacteria there. Then bacteria in the biofilm are in this dormant phase. Experiments, you get a big biofilm. Susceptibility to the bacteria, planktonic. MIC1, susceptible. Surface of the biofilm, MIC2, partially. You go deep in the biofilm, you can get in the bottom MIC100, completely resistant. And we're working with the bacteria floating around from microbiology. Polymicrobial biofilm. If the patient has osteomyelitis or a catheter and you have one MRSA and one enterococcus, when we discuss the bacteria exchange genetic material to transfer, there is nothing better than to be in contact in the biofilm. They can live happily ever after. They can exchange DNA material. There is no problems. And this is why the MRSA was able to get from the enterococcus, from the VRE, for the vancomycin-resistant enterococcus, the genes to be now an MRSA resistant to vancomycin, usually in biofilms. Then this is the way that we look. There is the bacteria, the antibiotic that is in the blood, the antibiotics that need to get to the bone, the antibiotic that needs to get to the surface of the biofilm, and the antibiotic needs to kill at the bottom of the biofilm. And essentially, Then susceptibility according to MIC. We need to have a susceptible organism. We definitely need an organism. Always bone biopsy. We need an organism. Then optimal killing that is going to be based on essentially optimizing dose. The antibiotic is time dependent, concentration dependent. And then optimal serum activity that sometimes we do a lot of what we call our killing levels. That we get serum and we in the laboratory have the organism, the antibiotic in the serum and figure out the killing of the organisms in the serum. Then essentially this has been a brief overview of what we're doing in our bone and joint infection services, a different approach, and I encourage the internal medicine residents to select the 2 weeks rotation in our bone and joint infection service to get exposed to some of these discussions in our daily rounds. And with this, thank you for your attention.
Thank you, Julio. That was incredibly informative. I have to admit that there are very few grand rounds where I leave the grand round more anxious than when I walked in. I'm about to get on a plane to go to San Diego, and I'm already worrying about biofilms in my psoas muscle. But, you know, we continue to look at bacteria and find ways to kill them with new antibiotics, and the bacteria outrace us every single time. So then we think about the host and we think about good nutrition and so forth. Are there any new modalities in the future that you can anticipate that address host resistance?
Yes, well, in the case of biofilm, for instance, prosthetic joint infections, the idea is you have now these prosthetic joints that are covered with antibiotics, because once you put a foreign material, the foreign material, whatever the foreign, you're going to attach this albumin, these proteins, and this is a perfect area for bacteria to attach. At this moment, the answer is the foreign material needs to be removed, and then you give antibiotics. Sometimes the foreign material cannot be removed. This is why you have a line infection. It's biofilm. The line needs to be removed. Now you give antibiotics, and patients you have a line infection with E. coli. The patient has cancer, chemotherapy, low platelet count. Well, we don't want to remove the line. We don't want to change the line. We give antibiotics. And the post-blood culture for E. coli became negative. And everybody's happy, assuming that, but you have the catheter. You have all the biofilm. Some E. coli jumps into the blood. You give antibiotics. Of course you're going to kill this guy. I mean, the guy is totally unprotected. I mean, the blood cultures are going to be negative. But what happened in the biofilm? The bacteria stay there. You stop the quinolone, and in 3 days, the patient is septic again. Then at this moment, these are non-winning situations, these infections. You have to remove the foreign material, or you have to do surgery and remove the biofilm. I have to tell you that most of the research in biofilm is happening in industry, because I'm not too much into this, but if you are a big person with a lot of dollars in oil, one of the issues of all these pipes that cross continents is the biofilm inside of the pipe that damage because this you have bacteria staying biofilm. But at this moment, we don't even, what I think is coming is in the laboratory, developing a biofilm. I start testing antibiotics, how the antibiotics work inside of the biofilm. But nothing from the perspective of white blood cells, of antibodies, or cytokines. In plenty of other infections, we always look at the host response. For these infections, once you have the biofilm, it's very difficult.
Questions?
The question is, do we have any new images for these type of infections? It's interesting because, there's not agreement still. This is a new evolving field. They were discussing a case that the patient has 6 days of positive blood cultures for MRSA. Sometimes we see this patient. We give vancomycin, we give something, and the patient keep having blood cultures. In our mind, the antibiotic is not able to kill the planktonic bacteria. Imagine what happened in the biofilm bacteria. This is a serious problem. Then, and then the patient, we have an echo. That means the patient is going to have endocarditis. And we have an echo, and the echo report said there is no vegetation, there is a clot. Well, in our book, it doesn't matter. I mean, this clot is a big biofilm with MRSA inside. Then it's a matter, sometimes we discuss things with different approach based on where are we coming. Then any type of growth that you have in an area, when you have bacteria and you are suspecting biofilm, it's going to be a biofilm infection. I think that the best, now I go back to, I think that the best image study that we have now is a PET scan. Because even though PET scan, the problem that we have is that unless you have cancer, we cannot order PET scan. Then we always try to figure out what cancer we can give to the patient to order a PET scan. Because I was insurance not going to pay. But in PET scan, I remember seeing, I was convinced, when we have a patient that was persistent positive blood cultures, we're looking for the biofilm, we couldn't find, all the echoes were negative, and the PET scan, you can see the wire of the pacemaker all light up. It was the pacemaker biofilm infection that the PET scan detected. I say, wow, this is going to specific areas of inflammation. And then, essentially, because without seeing a vegetation in the pacemaker, you're not going to send a patient to remove a pacemaker. So you didn't have a vegetation, but you had the full biofilm around the wire. Then probably the best thing that we have now is PET scan.
Is it more sensitive than gallium scan?
Oh, yes, much more sensitive, yes.
Questions?
Yes. Well, probably what happened is that at this moment, a lot of things that we are seeing now is because we are living longer and we have the possibility to, because essentially biofilm is interested, even though some people, biofilm doesn't happen there's a question. You have a patient with pneumonia, 7 days of infection, probably you don't have biofilm. Everything is still planktonic. But every time that infection moves from acute to chronic, you assume that it is biofilm. This is why, and for instance, in respiratory infection, you go to chronic sinusitis. Well, you have chronic sinusitis, it's not just the maxillary. You have to assume the maxillary and a big biofilm with the bacteria there. Then once the bacteria infection moves to chronic, is because essentially what developed the chronicity and the difficult to treat and the recurrence is because the bacteria is living in the biofilm. Then in otitis media, a child has pneumococcus, put a needle, pneumococcus, keep recurring. Then one day he has to have surgery and he has to have a tympanic tube. You get a piece of the tympanic membrane, you go there to electron microscopy, the streptococcus pneumonia is there in biofilm. Then it's chronic otitis, is the pneumococcus in the biofilm. How you're going to resolve? The question is, are we using the correct antibiotics for bacteria in biofilm? And this is a big question that I have now. Because the best antibiotic for Staph aureus, methicillin susceptible, I have to tell you, is cefazolin. And this is in the book. I was raised with this, probably going to die with this. But then I question, I have Staph aureus in the biofilm. Cefazolin is a beta-lactam. Kill when the bacteria are multiplying, in the growing phase. All the bacteria are dormant. Cefazolin doesn't penetrate into the biofilm. And even if it penetrates, the bacteria is not multiplying. What are we doing with beta-lactams for an MSSA in biofilm? I don't know. I don't like the idea, but I don't have anything to support. But we are questioning our management of this infection.
Julio, one of the reasons you treat mycobacteria in a different way is because of their slow growth rate. Is the approach you think should be done for biofilm-related bacteria?
No, it's interesting because, again, in tuberculosis, this should be, if the bacteria is slow grade, and sometimes you don't have a particular, and you have to kill bacteria. Because one thing is, Mycobacterium tuberculosis, for instance, is growing inside of macrophages, intracellular. For this one, we have a lot of antibiotics that we can take care of intracellular, or we can use 2 or 3. The issue is that still the bacteria, E. coli multiplies every 20 minutes. Mycobacterium tuberculosis multiplies every 24 hours. There are differences. We need multiple antibiotics, but the mycobacterium doesn't develop biofilm. It's still floating around someplace. Then intracellular is a problem, but we have a lot of antibiotics that has good intracellular penetration. What we don't have data is what happened in biofilm.
one last question. Julio, thank you so much. I appreciate you coming today. I assume that this group is mainly focused here and at the outpatient clinic. Are we extending this to Jewish Hospital and other members of the Kentucky One Health family, recognizing that a lot of our surgical procedures are now being sort of moved into other organizations? This issue is going to become it's going to go beyond
one thing that I didn't discuss is that we started a study that is a IV to oral switch therapy in osteomyelitis that we started enrolling patients, a prospective randomized study that we got approved, is registered in clinicaltrials.gov. We got approved in University of IB. We got approved from Kentucky One, and we started a study at the University Hospital. And Kentucky One is very interesting. I received a call because a big proportion of the expenses of these patients is send the patient home on IV antibiotic. Then I received a call from the group of research from Kentucky One that they would like to expand this osteomyelitis study to other hospitals, but they are discussing with me the possibility to do this in the full Kentucky One, in the full CHI network. And then I've been having a teleconference with some orthopedics from other CHI networks to see if they want to do this study. Then probably we're going to expand. We may want to expand our research operation. But the clinical service, we're extremely busy here. I don't think that unless I get new faculty. But this is the University Hospital will be our case. But we would like to definitely expand with Kentucky One and CHI our research possibilities.
Okay. Thank you, Julio. Thank you.
Okay. Thank you.
Very good. Thank you so much. Appreciate it.
Julio, tienes tantas cosas buenas. We need so many more people.
Yeah, this is.
Necesitamos más gente. And I don't know how to do it.
It's a national problem. Because I get emails every day from patients saying, one of your fellows to be in service.
¿Sabes lo que me gustaría que consideraran, Julio? Yo sé que usted ha organizado con Bolín y otra gente en microbiología, but I'm not sure there's a lot going on. Is there a lot going on?
No.
Tú necesitas uno o dos PhDs en tu laboratorio, en tu división, que están haciendo
Biochem research and people. So now you have clinical patient care, epidemiological, basic programs, laboratory basics.
I have to tell you,
You need all the above.
I have to tell you that Alan was planning to do on a job that he's was supposed to be working in the lab.
I know.
This was.
Well, my point is that PhDs are cheaper, depending on if you have laboratory space and that kind of thing. And we have laboratory space. And number two, we don't need UOP for them because you can potentially get resources from a clinical trial or whatever that pays them. And once they get their research going, they can fund themselves.